Welcome to Building Better Businesses, an ABA podcast. Learn firsthand from business owners who've built successful ABA businesses. Utilize proven techniques and strategies to help your practice thrive. This is Building Better Businesses, an ABA podcast with Jonathan Mueller.
My name is Jonathan Mueller. I'm the host of Building Better Businesses in ABA. And I have as a special guest with me today, Yagnesh Vadgama, who is the president and COO of HAI California and the VP of Clinical Care Services, Autism at Magellan Health. Yagnesh is a BCBA and has more than 18 years of experience in the autism services field. In fact, he started his ABA career by providing direct care to clients in homes, schools, and community-based settings. Yagnesh, welcome to the pod.
Hey, Jonathan, thanks so much for this.
Yagnesh, it's awesome. I remember we first met a few years back. It was pre-COVID, I think at a conference in maybe Philadelphia, and you were on a panel. And as always, you're like this like Obi-Wan Kenobi, Yoda wisdom of payers. But there was this really striking, and you were talking about sort of where the field was, how Magellan thinks about ABA services and where we're headed. And there was this really striking interaction based on a question from the audience about like outcomes and where we're going. And you made this really compelling point. Hey, look, we don't want to be the ones pushing outcomes down on providers. We want you all to come with us. And then I think the person asking the question, or someone who was like, wait, hold on, no, you tell us what the outcomes are. And it was just this really crazy thing that I think like really helped open my eyes to, we still have got a ways to go as we think about outcomes. But that crystallized in my mind your Yoda-ness, and you've helped me learn.
Thanks, Jonathan. I think it's, first of all, I appreciate that intro. I'm really lucky that I come to this space in my position here at Magellan, in a unique place where, like you had said, I was in clinical practice for 11 years, right? I still fondly remember being in the home, school, and community setting, sitting at the table, talking to parents during parent training. I myself, as a behavior technician, working with other BTs in the industry as they're coming up, seeing young minds growing, and now being in this position in Magellan and working with my team of behavior analysts that we have here, constantly having ongoing conversations around, we're only going to be as strong as our provider community is. And so any opportunity I get to espouse that and reinforce that, then that, this has to be a collaborative process of what we're doing here in ABA. It has to be providers. It has to be the funding source of the managed care organizations. It has to be the member. It has to be the autistic community. It has to be the science. We all have to work in concert together.
So well said. And I want to dive into that more. Like this idea of like, there's this like trifecta of stakeholders in the family, the ABA provider, and then critically the payer, right? who's an important stakeholder because you all are paying for the services. So it has to be approached as a partnership. I love how you describe like we're only as strong as our provider community. So I want to get to that in a moment. Tell me about your origin story. What inspired you to become a BCBA?
Yeah, sure. Absolutely. So my origin story is I started in 2004 when I was at University of California, Irvine. I was finishing up my undergrad, and a friend of mine had said, hey, Yagnesh, I know you're looking for job experience. There's this company who just opened up its doors in Orange County, actually in Irvine, and they're willing to hire anybody. So I think you might have a chance. And I said, let's take a shot and see what ABA is. And I did some research on it. I had learned about TEACH at that time, and I had learned about some other interventions. And I went into the interview, and I was really lucky. They gave me a shot. And that summer, I remember doing training and going into homes and just being absolutely almost as if I was like a deer in headlights when I first started, and thinking to myself, this is an entire population and an entire world that I had no idea about. Like so many people in our industry are personally impacted with autism in their family, and I'm not. And so it was a very new and exciting industry. But what really got me to buy in at very early on is, my dad is a medical professor, and he teaches. He's always taught at university levels, conducted research, and my mother is a high school teacher. And so in some ways, what got me in early on is that ABA is this almost beautiful amalgamation of a hard science and teaching and counseling and therapy and patient-centric approaches. And looking at it from a single subject design where I'm able to see in real time, are my clinical interventions working? And I like to think of myself as a highly competitive person. I'm a very, I push myself really hard. In what better field than ABA? And there's this sense of competition that always drove me when I was in the field, and even now here at Magellan. And what can I do better today than I did yesterday for this family and for this individual and for the situation that they had in front of them? And really, that's what kept me going, Jonathan. It was a couple of years doing direct intervention and then working my way up into supervision and then getting my master's and getting my BCBA, and then constantly having a thirst and a desire to wanting to know more. What else can I do differently? And then about 7 years ago, I really wanted to see, okay, well, I was able to do this at a micro level, working directly, right? I don't want to, micro to be misinterpreted at a small level, but more of a one-on-one level. What can I do at a macro level? At a big, how can I start to change systems? How can I start to advocate for our science at a larger level? And so I started looking at opportunities. And 7 years ago, I started working at Beacon Health Options, and I was there for a year, primarily looking at the Medi-Cal space here in California for Medicaid services through Beacon. And then my old mentor, Tim Crilly, who was in my position here at Magellan before me, had said, "Hey, Yagnesh, I'm on my way out. Would you mind recommending you for this position?" And luckily, Magellan took a chance on me. That was 7 years ago, and I started as the director. And I've been really happy with that growth since.
Wow, it's such an extraordinary. Just having 18 years in the field makes you OG, man. Like, very few that could reference that. And I'll never forget. I'm reminded constantly of the power of our science. But having a kiddo who, for the first time, she was 8 years old, and as part of the interventions, I got to see, like, she said, "I love you," to her mom for the first time. And I swear, dude, there was not a dry eye, right, in the house, literally in their house, that happened. I mean, our science is extraordinary, and our science has come so far over the past few years, over the past decade, right, especially as Medicaid and commercial payers are now paying for services. But what are some of those most important strides you've seen our field take?
To me, it's a great question, Jonathan. To me, I think it's a hyper narrowing in the focus of what we do, right? I really believe that the regulations that have come across every state, right? So, people like through Autism Speaks have done just tremendous work in getting the mandate across all 50 states, right? And pushing awareness of autism, pushing the validation of ABA. There's countless people who have pushed our science to the forefront. What makes our science so beautiful as well is that we're so young that everybody's still here, right? It's not as if we're looking at 50, 100, 200 years ago of the science and what our founding fathers were. No, our founding fathers are still in front of us, and that's really exciting, right? I've been in this game for a long time, and I still go to conferences and I geek out when I see the people like, I literally was just reading their research articles last week. This is incredible. And so what makes me so excited about where we've come is there's greater parity where families now know what they're getting. ABA isn't this almost this dark corridor that people don't know what am I getting into. There's a lot of awareness now. There's a lot of vocalization. You can read more articles around it. You can look at what outcomes are. You can see tangibly in front of you, am I trending in the right direction? Yes or no, through visual analysis, right? And so I think that's one of the greatest parts is now on every case, you have to have either BCBA or an LBA, depending on the state. Many, many places, you have to have a minimum of an RBT on that case as well, or a BCAP, whatever the credential is. When I started in the field, it wasn't like that. And I'm almost embarrassed to say that when I was initially providing supervision without a BCBA and thinking, what was I espousing? What was I doing out there? But now everybody has this great qualification. The number of BCBAs each year are rising through the roof. And the fervor and the excitement of the youth that are now coming into this industry is just phenomenal.
Well said. It's funny. I'll never forget in 2013, I think was it 2013 or maybe 2014? I was at the time working for a large national ABA provider, and I was in Ohio, and I was driving in a rental car, and I heard, or somehow I read, like, oh, CMS has provided guidance that ABA services should be paid for. And I remember thinking, that's awesome, and whew, this is going to be a long road to hoe. It's going to take time to get there. And yet we've gotten there. So to your point, this stuff is almost happening in real time, right? And I know a lot of this is like, hey, we can't happen fast enough. Yes, I get it. And this is happening as powerful in real time. So progress is being made, but there's still places that our field's falling down. Where do you see us falling down?
Yeah, it's a great question. And I think where I see the biggest challenge in our industry is we've done a phenomenal job at getting others to recognize ABA as an empirically validated science to work with individuals, right? I don't want to say individuals with autism, because of course ABA is not just for individuals with autism, but it being our primarily source of funding. But I think what we got to do a better job at is, I think what did the BCBA say? 95% of individuals in our industry do work with the autistic population, right? I think what we got to do a better job at is understanding the population that we work with. And if we can take a step back and start to understand autism and listen to the autistic community and listen to those who are impacted or do live with autism each and every day, and how can we better serve them? How can we start to better understand rates of diagnosis, the disparities in the diagnostic rates on a state-by-state level, the disparities by ethnic groups, the challenges and the stigma in certain ethnic groups in getting that diagnosis. Time is of the essence, right? If we're looking at ABA, we know that the brain has the greatest plasticity at a young age, and yet a child with Medicaid will get diagnosed oftentimes 2 years later than somebody with commercial insurance. And so how can we deconstruct our ABA practice and start to reconstruct it around autism practice and start to really look at the medical model and collaborate with other professionals, going beyond the speech OT, PT, but start to look at psychologists, psychiatrists, those with the pharmacological interventions. How can we start to really wrap all that around and putting ABA at the forefront of it and saying, look, we're here every day, medical professionals, how can I work with you and how can you work with us so that we're all on the same page?
So this is a really important point that I want to make sure that I'm reflecting back. That, like, this is not, as we think about serving individuals with autism, we're thinking autism services as opposed to just ABA. And yes, to your point, I mean, like, the intensity of services just mean we're going to be there showing up every day for families. But there's this whole series of wraparound services that are not just the speech, OT, et cetera. But I mean, what is it? What are the stats on, comorbidities? What is, like, 50% of the kiddos with an autism diagnosis have, a second diagnosis of other mental health or other things going on. There's all kinds of GI issues that ABA certainly is not, like, qualified to address, because they at their heart they're medical. There's sleep issues. I mean, there's all this stuff, right? And I think that's what I'm hearing you describe is, like, let's approach this individual with autism from that spectrum of, like, what are the broad set of needs they have, of which ABA is a critical component, but there's a lot more out there, right?
Yeah. Jonathan, to that point, right? And we can use behavior analytic terms and terminologies in understanding that, right? Setting events, for instance. What's happening behind the scenes that are impacting your clinical interventions? You mentioned it, sleep, right? High rates of sleep disturbances within the autistic community, high rates of GI issues that we've yet to really fully understand that, right? I think a tremendous example of that is within the autistic community, those who are nonverbal and have constipation have much higher rates of severe aggression. Well, if you don't have a means to communicate that, hey, I'm really hurting on the inside and you're trying to get me to eat, you're trying to get me to do things, and I'm having just nothing but abdominal pain, but I can't communicate that. How else am I going to find a way to communicate that? But if we're not looking at it, again, in ABA, parsimony, if we're not looking at it from what's the most basic answer that's out there, it could just be Miralax. It could be, let's go get an appointment with the GI doctor. And to your point, Jonathan, this is the part where I think we got to do a better job at is how can we start to bake in either screening or regular checkups with those medical professionals so that our intervention we know is optimal.
Mm. And I mean, this is something the rest of the medical world does just as part and parcel, right, of treatment. That is like coordinate care, generally through a primary care doctor, who kind of runs air traffic control, right, has a relationship with the patient and can, yes, go out to other specialties. But like it feels like care coordination is a critical part of this. And why is like, I don't know if you have an example of where you've seen care coordination work really well, whether it's in our field or another healthcare field, or help us understand like what ideal care coordination is.
Yeah, you're right. You know, I've seen it in this is one of the exciting parts of where our field is going. There's an emerging group of thinkers and innovators in our industry that I'm seeing now on my side across the country that are taking that step back and saying, okay, what else can we do in the care coordination space? How can we start to have greater clinical rounds and work with medical professionals in our community that we can do a direct referral source to for those comorbid concerns? And, you know, that's similar to, you know, if I'm going to, you know, the primary example I always give is years ago, coming back to me being competitive, I was playing men's slow pitch softball and I should have settled on a single. And instead I tried to stretch out a double and I snapped my quadricep muscle, the rectus femoris. And I went to my PCP and the PCP said, you know, I think there might be a concern here. I'm going to refer you to this orthopedic. And I went to the orthopedic and the orthopedic said, hey, before I do anything else, I'm going to refer you to to a physical therapist that I know and trust. So I went to the physical therapist. The physical therapist said, you know what, this doesn't look like it is a pull or a strain. I'm going to send you back to your orthopedic and ask for an MRI. Got the MRI, went back to the orthopedic. The orthopedic said, you know what? Yeah, you do have a tear. We're going to have to go for surgery. So there alone, there was multiple referrals that were happening with me at the center, and each one of them communicating with each other. Had the surgery, and then immediately my surgeon 2 weeks later called me and said, how's it going? Here's the number now for your physical therapy that you're going to have to go through. It was a different physical therapist because it was a post-op physical therapist, right? Now, this is one of the things in ABA as well. Can we start to tailor our interventions and our specific focuses on what our specialty is or what our area of focus is? Like this physical therapist, a post-op physical therapist. I went to them and they continued to guide me along the way, making referrals to other places. They had even made recommendations. Hey, do you want to start to look at maybe a group physical therapy? Do you want to get into like a bicycling club? Do you want to get into a running club to get you back onto your feet? And that is what care coordination would look like, right? How can we wrap around and have an understanding of links to community resources, other professionals in the area that can best serve you along your path for recovery?
All right, so much of what you're describing resonates. What I love about that is that, hey, you were the expert on your body, right, and your quad, but you didn't. Your medical community surrounding you and that team was proactive in driving toward sort of solving what was going on. Let's figure it out. Now let's figure out what has to happen next and subsequent, et cetera, as opposed to you being the one that has to drive that. And it feels like so many times now, families with autism almost are put in the driver's seat. Like they've got to go advocate. They got to figure out, is it this or something else? So on that note, and by the way, I still love, and I play in my old man beer softball league. A night, Yagnesh, that I don't pull a groin or a quad or a hammy is just a good night in my book. So I get your analogy. But in this new world, is that, you know, is it the ABA provider who might be at the center of care coordination, just given the relationship? Is it the pediatrician? What are your thoughts?
It's a great question. It's a question, honestly, Jonathan, that I hear from so many providers, right? It's why should it be us? Why should it not be somebody else? Well, we're there, right? We're there every day. We're there with the family. We forge those relationships. We're the ones collecting the data. We're the ones that are looking at the outcomes. We're the ones that are constantly looking at how has my intervention progressed over time, right? part of the job of the behavior analyst, every time you're walking into that home, is to continually make modifications on the treatment plan to see, okay, well, what do I got to do next to get this individual to the next potential level, right? It does have to be the behavior analyst. And I think it's a tough conversation to have, frankly, because nobody taught us this, right? And it's something I do want to recognize. In our schooling under ABA or in our master's programs, nobody taught us about care coordination and wraparound services. In fact, nobody taught us as well about autism, and nobody taught us about high rates of comorbid conditions and what else exists out there. And so it's something that we also have to learn on the fly. And for better or worse, it's something that we have to do to better serve the communities that we're working with. And so why does it have to be us in the care coordination? Again, we are there almost every day, right? You're getting authorizations from anywhere from maybe 10 hours to 30 hours a week. We're working, we're forging those relationships. And so it's our part of our responsibility within the medical model to be able to ones to almost be like a quarterback and pivot all the way around of what kind of services do we need to throw in here.
Oh, I mean, it makes so much sense, right? This is going to sound inelegant. We, quote unquote, we own that relationship. Families trust us.
Yeah.
Right. So we can help them as opposed to they go to the pediatrician once every 6 months or a year for well child checkups. We built that relationship. They can trust us to say, hey, you might want to go get that, constipation issue or that sleep issue checked out. Let's go rule other things out. So it makes so much sense to me. And so on that note, interestingly, I'm curious, I don't know if you have a view in the rest of the medical world, like how does that get funded? Is that generally like a separate, I know there are care coordination codes, but is that sort of a separate set of services that end up getting funded? Is it something that just gets baked into reimbursement rates? How does that work elsewhere?
Yeah, oftentimes there is separate care coordination codes that are available, but and oftentimes in terms of ABA, it is a part of the bundled rate in that which we have, right? And it's something that we saw when the AMA came out with the permanent codes in 2019, that the permanent codes did say that your rate is a bundled rate for your non-direct hours. And in the past, with the HCPCS and the T codes, you could do those services and bill the insurance company for that, right? For now we can't, but it is a part of our bundled rate. So it's a part of our overall service, overarching services. Now, I do want to say, part of our future state of behavior analysis and ABA of value-based contracting and case rate models, et cetera, that is definitely going to be helping out with that care coordination and coordination.
Yeah. Well, one of the things I know you and I are just like so passionate about is getting kiddos access to the highest quality life-changing services. Like what, in your view, what's the single most important thing you think ABA providers could change in order to make that happen?
It's how can we start to really look at what outcomes look like? And this is the part that, coming back to the original conversation, right, around outcomes and who's going to be driving those outcomes conversations. We have to have open and honest and ongoing dialoguing conversations around outcomes for not only ABA, but outcomes for autism. How are we doing? Are we narrowing that gap between the chronological and developmental age? Are we putting the individual on path for what are we planning towards into the future? Is it a vocational program? Is it independent living, right? Is it college? Is it what is it, right? What are we planning for? And are we successfully driving our programs to get to that level? And I think that's it, Jonathan, is that we have to have these productive conversations around what are we trying to do? And unfortunately, oftentimes we have to have uncomfortable conversations around, hey, we're not going in the direction that we thought we were going to go into. So we're going to change. We're going to go into this other direction. And here's why. Let me show you what the progress looks like. Let me show you what the Vineland scores look like, or the ABAS scores look like, right? And coming back to not only what the science is, but validated scientific tools and measurements. Nothing subjective. And having those direct and honest conversations. And I think that's what we have to also do as an industry, is we have to have those conversations ongoing with the members, with the families, with the funding source, with our colleagues, and just be open and honest, right? And I think that one of the challenges that we have in ABA is we're so emotionally invested in the individuals we're serving. And you know what? Justifiably so. We should be emotionally invested. If you're not emotionally invested, you're in the wrong field, right? And so, but how can we separate that emotional investment from the scientific intervention around medical necessity? And I think that's what we have to do.
So well said. especially like we've grown up as a field. It feels like we're a field of like fighters, right? We've had to fight for access and to get funding. We had to fight going back to IEP meetings, right? That, the pre-BCBAs behavior analysts were sitting in and probably pretty uncomfortably, right? Trying to explain what they were doing. So we've always been fighters. And now, like, how do we make sure that we're not like a circular firing squad fighting inward on ourselves? And I love that you described like in the Vineland, right? Which, okay, it's not, it's absolutely norm reference. Maybe it's not the perfect measure because it's not specific to autism, but just that question of, are we narrowing the gap between chronological and developmental age? That's a way that we can start to look at population health measures, it feels like to me, while also honoring the individual and the very highly individualized treatment plan, right? Instead of outcomes any given kiddo has. But that seems like a no-brainer, right? Why isn't that happening?
You're absolutely right. We have these tools that are right in front of us. I think that there's a fear and a trepidation out there that if we start to narrow our scope into these particular measures, that all of a sudden they might be taken away versus the clinical input of the behavior analyst or the clinician on the other end that is saying, no, but actually here's why, despite what the Vineland is saying, here's why I need to continue, right? And so I think that's why, is that we don't want to, I think that the industry is fearful of narrowing our profession into the hands of these tools, which I fully understand, right? As behavior analysts, like all other clinicians, you're able to make your own independent clinical determination. But what are we going to use to support that decision? And I think that's the key part, and that's the honest conversation that we have to have is, okay, well, sure, I see that the gap between the chronological and developmental age is actually widening. Okay, well, what support me, help me understand, provider, what is it that we have to do, and what are you trying to do to continue with the rate of services or increase your rate of services? What's out there, and demonstrate that to me.
And one thing I think I've heard from you, so correct me if I'm wrong, but a provider sharing that data with you, with Magellan, it's actually really powerful because it facilitates a conversation, as opposed to your first reaction is not going to be, oh, well, then like pull services, right? That's something you want to see, whether it's good or bad data, and have a conversation around. Is that right?
That's absolutely right. It's absolutely right. It's by sharing the data and having these ongoing conversations, it allows us to then give to the provider, oh, I see that I see that your phase change line is indicating that there was a sleep concern here, or that the parents started giving melatonin, right? So we're going to put a phase change line in there because now we're starting to use melatonin because we're having struggles there. Hey, have you thought about a sleep specialist? It's like, no, we've never had that conversation. They just started to give them melatonin. Okay, well, hold on, let's pump the brakes. I'm going to get you a list and a referral in your zip code of all the sleep specialists that are in network with you. And let's coordinate that. So I'm going to give it to you, provider, and let's start talking about this. And I'm going to follow up with you to see how we made that meeting. Have you got that first appointment there? Right. And so again, leaning on what other services, what other professions do, looking at something like HEDIS measures, right? Follow-up appointments, follow-up after hospitalization appointment, follow-up dentist appointments, PCP appointments. Are we doing these things? That is a key part of sharing that data and being honest with us, is that we can help. And that's what we want to be able to do, right? At the end of the day, we want to see these members and these patients, these kids, whatever we want to call them, whatever the nomenclature is going to be at that moment, we want to see them successful.
Let's double click on the HEDIS measures, because this is something that I think most ABA providers aren't familiar with, but very common in the rest of the medical field, especially with like pediatrics, right? So you have a very standard set of ways of reporting back on things that are important to best serving a kiddo, as a pediatrician, say. But can you talk a little bit more about HEDIS measures, maybe one, and then two, what's it going to take for our field to move toward having those measures?
Yeah, sure, absolutely. So at the very highest level, HEDIS measures give us a means and a benchmark of everybody performing at the base, at the bare minimum. This is what we have to be able to do, right? We have to be able to do a particular set of metrics for this particular clinical diagnosis or this industry. We don't have that in ABA, largely because ABA is built on a single subject design. But, well, how can we start to take a step back and maybe build our own HEDIS-like measures in behavior analysis? How can we start to look at it from the lens of, okay, well, within autism, what else do we got to do? right? Knowing that, again, like what you had said earlier, high rates of physical and or behavioral health comorbid conditions. How can we start to put those screening measures into place, make that part of our regular clinical practice so that we are providing the individual the opportunity to make sure that if there's anything else there, that we're screening for it. Or if there is something else there, again, in the care coordination model, that we're helping to follow up to make sure that they are seeing their appointments, that they are going to it, that we're assisting them with it. Because I can guarantee this, right? We've all worked in the industry. Even though we're starting to look at care coordination and we're starting to get them into other services, they're still going to need us as behavior analysts. They're still going to need their RBT at those appointments. They're going to need us to help disseminate from a scientific level what is the acuity of the behavior, what is the rate of the behavior, what is the function of the behavior, why is it happening? We have to disseminate that information, right? Coming back to the 7 dimensions of ABA, it's our responsibility to be able to use those technological terms and ideas and disseminate that to other medical professionals.
Well said. ABA practice owners, are billing and insurance issues getting you down? Well, let me tell you, Element RCM is your answer. Element provides world-class revenue cycle management services, contracting, credentialing, authorizations, billing, and more. Element's your partner, so you can focus on what you love to do, providing the highest quality services to your families and clients. Element's a preferred partner of the Behavioral Health Center of Excellence, and its founders have nearly 20 years of experience owning and operating successful ABA organizations. They understand you. They know that every dollar counts, that integrity is everything. Element works with any practice management system, and Element's not a vendor, they're your partner. So find out more and take a free revenue cycle assessment at elementrcm.ai. So like another thing that comes to mind in thinking more holistically about a kiddo, the family, and whether we're being effective, the parenting stress index, right? The PSI, which is right, evidence-based tool that like says if we're actually helping reduce parent stress levels, which I appreciate. Hey, we're not there 24/7 for the families, right? So there's other stuff that's happening in life that maybe we can't address. But it feels like just using that type of norm referenced evidence-based measure is just another data point in how are we doing in best serving this family, right? And then the same thing is like if we're not narrowing chronological age to developmental age, I mean, if parents are more stressed, that's probably a good question to like and a conversation to have with them. But would that be another example of a way that we are bringing tools to bear to help best understand how effectively we're serving kiddos?
Yeah, absolutely. I mean, while we know outside of the academic, in the academic setting, we're able to look at what outcomes look like, right? But outside of an academic setting, we've never been able to look really at group design outcomes metrics and what that looks like. But the one common denominator that we can continue to look at in group design outside of academic settings is parent participation and caregiver involvement in each and every case. So it's paramount for parents to participate in order to see the best outcomes. But it's also important for us to recognize, like what you were saying there, Jonathan, the incredibly high rate of challenges that families are going through at this very moment. We've all been in countless and hundreds, if not thousands of homes in our careers, right? That those challenges that those families are going through, you feel it when you're walking in that door. And what can we better do to serve the families in the entire familial unit, right? Some of the stats that always stand out to me is a parent with a child diagnosed with autism has the same cortisol levels as a veteran who's just returned home from war.
Oh my God.
Right. A sibling with a child, a sibling who has a sibling with on the spectrum, end up developing behavioral health conditions much later in life as well. And so what are we going to do to better serve them? So the things like the PSI, and then telling that family, look, I see that you scored positive here. We're going to work on coordinating to get you to potentially what services can we get you so that you're better served. I obviously I do what I do here at Magellan, but on the side, I also consult with families. And oftentimes with families, when I'm consulting with them, it's not me coming in with some ABA intervention. It is, what can I help you out with care coordination? And at the center of it all is talking to the parents. what are you doing to take care of yourself? Because if you're not going to be able to take care of yourself, which I understand with everything that you have going on, but if you can't take care of yourself, how are we going to better serve the community as well, right? And so I think that's a challenge that we have to really face head on.
I love that you're opening up the aperture, Yagnesh, around like how to think of this idea of quote unquote autism services, not just ABA services. It's something you referenced earlier as well. Was sort of just maybe it's in setting events or the circumstances more generally that a family faces. And I think our payers and more broadly as communities, we think about these as quote unquote social determinants of health.
Yeah.
Right? And these are all the rest. Do you have access to, to enough to eat, right? What might be other risk factors? Can you speak a little bit more to how, as a payer, you think about those social determinants of health and how important those are toward an ultimately successful outcome?
Yeah, Jonathan, I'm really glad, and it makes me happy that we're having this conversation on social determinants of health, right? Because it's something that we don't necessarily look at in ABA. And if I could be open and honest and uncomfortable here in this next part, is that we have to do a better job at diversifying our clinical practices in ABA. I think so often that we take this homogenous approach from one particular cultural perspective of how ABA should be applied, but we're not taking cultural implications or religious implications or Medicaid versus commercial implications into consideration when we're tailoring our particular treatment plans. I remember being at a conference and hearing a parent, she's Middle Eastern, and I remember her son was a teenager, and the behavior analyst had said, we're going to get your child to learn how to fold clothes. And she said, well, why? Why should he have to fold clothes? What does it matter if he folds clothes or not? They said, well, that's going to be independent living. She's like, who cares? Independent living, he can live with me as long as he wants to. Why does he need to be independent? And so it's social determinants and not focusing in on social determinants. And again, coming back to unwinding our ABA-centric approach and looking at it from autism and looking at it from what else is out there, right? Is it access to education? Is it access to early intervention services? Is it access to a PCP? Is it can we coordinate and can we get you over to a psychologist that will give you a true assessment versus something off the side of the table, right? Or, social determinants in a Medicaid population, oftentimes you get diagnosed at the age of 6 within a Medicaid population. Well, what also happens at the age of 6? You're going to school for the first time. So they're going to school for the first time. It's the first time that a teacher sees a child and says, hey, hold on, I think we got to get an IEP for you. Mm-hmm. Right? And so how can we start to look at it from that perspective versus we're just going to take this ABA approach for everybody and just do the same thing over and over?
I love this because, look, our field doesn't have to get there tomorrow, but this has to be, I think, part of the arc of how we think more holistically about kiddos. I'll tell you a personal story. It has nothing else to do with autism. When I, 17 years ago, I went and volunteered abroad. I was living in Tanzania, and I was living with a family. I was like a volunteer business advisor doing microfinance. I was working with families who had lost their breadwinner to AIDS and were looking to restart their business. It's just a profound and transformational experience for me personally. But I was living with a family. And I remember they had a few kiddos, and their oldest daughter was named Happiness. And in Tanzania, the tradition was you named your oldest daughter after the mom. And sure enough, Mama Happy, that was my host family. So anyway, so I'm getting to know Happiness. It's like the first few days that I'm there. And I ask Happiness a question, just whatever, some kind of just like banal question that needed a yes or no response. And she looks at me and raises her eyebrows and goes, and raise her eyebrows. And I'm waiting. I ask the question again. And she raises her eyebrows even more and makes this inaudible. And I ask the question again. This was in Tanzania. This was a way someone responded yes. And she was doing that so strongly to me, and yet I wasn't getting it, right? And this is just, and this is a small, but I think really critical point around what you're describing is not understanding cultural context. On a little thing, imagine what that does when you don't understand where the family's coming from and what their needs are, and not therefore provide the right set of treatment guidance and like what they need to do. So that feels really important, Yagnesh.
Yeah, Yeah, to that very point, Jonathan, it was, another study that always disturbs me, and something that I always mention is, in the 90s, Black children were more likely to be diagnosed with oppositional defiance disorder before they were diagnosed with autism. And the diagnostic rates of Hispanic children in this country are far behind the diagnostic rates of white and now Black children in this country. And so focusing on social determinants and cultural implications, and also coming to terms with, to be honest, with the way in which science is purported in our country, and the inequities within it, and what are we going to do to narrow those gaps so that everybody's looked at and treated equally, while considering the past trauma that we've unfortunately inflicted upon communities, and what can we do as stewards of the healthcare system to change all that?
Yeah, absolutely. Well, you used a term a little bit ago, Yagnesh, value-based care. And it gets tossed around a lot, which is actually super cool, because 10 years ago, I got in the field, like no one knew what the term was. When I started, my co-founders and I started Ascend 5 years ago, it was maybe 1 in 10 people knew. And now I'd say 6, 7, 8 providers out of 10 have at least heard the term. So that's cool. All right, put that in the win column. What does value-based care mean to you as a payer?
Yeah. So, we know that just about everybody right now is currently set up on a fee-for-service model, right? We take the 9 series codes, the permanent ABA CPT codes. For every 15 minutes that you're providing a billable service, you put it down, and then you bill the insurance company, and the insurance company will reimburse you for that 15 minutes of service. Value-based, if we take it from, we'll just look at a case rate model, right? There's a particular rate. It's not based on an individual 15-minute service, but there's a baseline threshold that we have to meet as providers. You have to be able to meet that. Once you've met that, then the case rate can get triggered, and then the provider can get paid on a case rate. So an overall rate versus the 15-minute service. What this gives us now is it gives us the opportunity to look at health providers, because now with that rate, now you can do greater innovation, right? Like we talked about earlier, care coordination. You can do the wraparound services. You can hold those interdisciplinary team meetings. You can have those grand rounds discussions. And rather than coming back and saying, well, you know what, Yagnesh, how are we supposed to bill for it? Well, now this is within your right to use this bundled rate at your discretion and how you're going to be able to do it. Now, why this excites me is it because it pushes innovation. It pushes providers. And this is in the here and now. So we piloted a value-based contract with a provider last year. This year, we're going to go live with another provider. And in 2023, we really want to be able to expand that out. That's our vision here at Magellan, right? We're very aggressive with it. I think anybody who's had the fortunate or unfortunate opportunity to hear me speak at conferences, I've been very honest and upfront about where we are with value-based. Future state value-based, why I think this is so important, Jonathan, to what you were saying. We can look at what other professions do with value-based and what other practices do. What we want to be able to do is, how can we start to differentially reinforce, again, using an ABA term, right? How can we start to differentially reinforce clinicians who are demonstrating clinical progress, right? So now let's couple everything that we just talked about in our discussion here. Taking those HEDIS measures, taking those screening methods like a Vineland or the Parent Stress Index or quality of life indexes or sleep or depression screenings. How can we start to say to a clinician, look, I see that you've done all these things. So if your case rate was at X, well, now we can give you Y, because you've demonstrated and you've gone above and beyond, and you're starting to really show that you're doing everything that you can in the individual's best interest. And at the end of it all, who wins? That patient, right? That kid, that family, that individual. Now they're getting the full wraparound services. Now we're incentivizing the provider to be able to do that. And now we're being able to see, okay, well, who's really making that progress? Big picture, long-term, Jonathan. Now we can tell families when their child is newly diagnosed with autism, they're trying to get into ABA, and say, here's a list of providers who who consistently and reliably demonstrate outcomes through these macro level interventions that we've been able to see. They're collecting data, they're doing metrics, they're doing screenings, etc. Right? They're wrapping around those services. Don't you want to go there? We do this in all over the levels of healthcare, right? When we want to find a healthcare provider, what do we all do? And we always brag about this, right? Like, I got the best of the best, right? I went to this hospital, I went to this university. It's natural, right? It's what we do. Why can't we do that in ABA? Right? How can we start to differentiate which providers are really pushing the industry forward?
Well, it seems like so much that comes back to, hey, let's just consistently report on outcomes. What's critical about this is, to your point, there are models, right, that exist. The Affordable Care Act, what was that, like 12 years ago this past, introduced this idea of accountable care organizations. And this is for, Medicare and different populations, clearly. But it was the idea that, hey, don't just pay a healthcare provider because they provide more procedures or because they bill more hours. Like, what does that do? Pay them for the outcomes, the quality of the services delivered. And it's been shown, these accountable care organizations, it's been shown that, like, quality stays consistent and or improves while costs come down. And that's to the benefit of all three of the stakeholders, most importantly the patient, but also the payer and the provider, right? So this just seems like a no-brainer. And, like, what has to be true, Yagnesh, for Magellan to enter into value-based care contracts with ABA providers?
What has to be true is we have to be able to have a consensus of what quality looks like, right? And so I'm glad that you had mentioned that. Is at the source of it all, it has to be quality, and there has to be a consensus on what quality looks like. Not Yagnesh at Magellan's opinion, but really the industry's opinion and what research and everything is looking like. I recently was a part of ICHOM, which is the International Consortium of Health Outcomes, and what an illuminating process to be able to look at what measures should we be putting into place, what different tracks to essentially phenotypically profile individuals, and what kind of measures should we start to put in there, right? And so how can we start to use things like that, or start to use tools and measurements like our colleagues do over at CASP or the BHCOE as an example, right? So we have just so many tremendous thinkers in our industry that are thinking about what do we got to go forward. At the end of it all, it's always quality, Jonathan. And how can we come to a consensus of what quality looks like? Right now, we're looking at quality using the Vineland. And again, what you had said, and we fully agree, the Vineland isn't a source truth of all, right? We know that, but it's a start. And that's what we have to do. We have to take a start. We have to put a foot forward before we can start to run.
So do you think, all right, I'm going to put you on the spot here. What's the over-under year? That is the year by which you think the majority of Magellan's contracts with autism service / ABA providers will have value-based components. And I say components just because there is a scale, right, of going from, hey, maybe just measuring outcomes to maybe having a case rate to, maybe you get some financial incentives to then probably at the farthest end of that spectrum, you're actually at risk as a provider, right, if you don't do it. So knowing there's a spectrum there, what is that year, you think?
I mean, I think you know me as well, Jonathan. I'm a wildly optimistic person, and that's what drives me. And so I'd like to say within the next 2 to 4 years, I think we're going to get there.
That's awesome. So if a provider was going to come to you, should they propose their own set of quality metrics? Should they look to our colleagues, BHCOE, ICHOM, CASP, who have identified, sort of starting frameworks? What would you recommend they do?
Yeah, starting frameworks of what they believe quality would look like, but then it's quality at a group design level. And I think that is the key component, right? We have to move out of the area of the single subject design, which I know is challenging, right? Because our field is not designed on a group design level. I totally understand that. But in order for this to work, we have to start looking at it from a big macro perspective of exactly what are we doing? Or again, looking at phenotypic profiles. When where an individual is coming in and we're doing our assessment, we're saying they should slot into this particular category or this category or that category. And depending on the category, this is potentially what the case rate is going to look like. And based on that, these are the measures that we're going to look like. And based on all of that, this is the projected length of time and services that we're projecting that the individual should be in. And again, I think that's something that we don't really talk about as a part of value-based. Value-based, unlike fee-for-service, is not indefinite, right?
Mm.
And that's the thing about fee for service. Right now, service it's indefinite. If some folks can go on as long as they want to, but on a value base, we have to have an idea of what that end goal is. Now, it's not to say at the end we're going to completely drop you, but at the end that value base might switch over, say, back to a fee for service instead, right? So we have to have those open and honest conversations.
And you know what's really important about, and I know this will get ABA providers freaked out. They go, oh, the end, and I can't say, but think of any other consumption of a service, not just healthcare, but certainly healthcare is a great example. As a quote unquote consumer of a service, I can picture what my life will look like when that service is completed. So if I go to the barber and I want to get a shave, right, because I don't have any hair on the top, but I've got this funky facial art going on, whatever it is, I can picture myself and what I may look like if I avail myself of that service, if I consume the service. Now that's sort of a crazy side example, but I mean, the same is true here. Isn't it our obligation as ABA providers to help families understand what could that future be for your kiddo?
Yeah.
What are the kinds of skills that we might be able to develop? Might they end up in a typically developing, gen ed classroom with minimal supports, right? But doesn't that feel like an important part of setting up the vision for parents of what their child could achieve?
Absolutely right, Jonathan. You captured that perfectly. The example I oftentimes come back to is cancer, right? And oftentimes in cancer treatment, and by the way, on the medical side of the house, 60% of all medical billing is actually on a value-based arrangement. And so, you take somebody with cancer, they're identifying what stage is their cancer. And you hear it all the time, right? Well, this is what the trajectory is, or this is what the expectancy is. Now with autism, obviously we're not talking about life expectancy or morbidity. What we should be talking about within autism is what is the severity level upon diagnosis. And to what you're saying, okay, well, you diagnosed at age 4, depending on the severity level. Okay, by 6, we're trying to get you into a gen ed setting. This is what we got to do. Or by 6, when we get you into school, we want to get you into school with support systems, right? And that's what it has to look like. This is what we have to do. These are the measures and the metrics that we have to get to. We're here at baseline, and this is where our future state needs to get to. And again, in every month that we're coming out there as behavior analysts, having those ongoing open conversations with the parents and showing them through visual analysis of where we're going. Are we trending in the right direction?
Oh, so well said. Well, let's pivot. And I know one of the pain points for a lot of ABA providers is around credentialing, right? So help me understand, why does credentialing, call it a BCBA, why does credentialing take a long time? And what can ABA providers do on their end, on our end, to speed that up?
Credentialing takes a while because we want to make sure that the people who are getting into these homes are safe. They pass the background check, right? That there's no concerns that are out there. This is a vulnerable population. They're young. We're oftentimes going into homes, and in some states, 90% of all of our billing is in a home with a parent there, and in some states we have 90% billing in a clinic with oftentimes no parent being there. So we want to be able to make sure that the individuals that are there have passed a series of rigorous background checks and understanding that, yes, they should be there, that your child and this individual is in safe hands.
Powerful. And I mean, I think just the basic blocking and tackling on the provider end is just complete the application, right the first time, right, when you submit it. Because here's what I think providers don't understand. If you're a listener, my guess is you are committed to quality. You are passionate about what you're delivering to kiddos. You're constantly wanting to do the right thing. And there's something like 7,000 ABA providers out there. So an important role of a payer like Magellan is making sure if this person shouldn't be going to someone's home, like, you have to vet that, right?
Yeah. And, something that probably won't win me any Christmas cards this year from the provider community is the vast majority of times that it takes a long time for providers to get credentialed is errors in the application process. And the one thing I would say to your listeners is make sure before you're submitting that everything has been double checked and double vetted, because by the time you submit it over, you're thinking, boom, we're done. In 30 to 60 days, I should have my credential. It should be okay. And then you don't hear from us. and then you end up seeing, oh, it got denied. Oh, well, that Magellan. Well, no, actually, we didn't get this particular area secured, so unfortunately, we had to deny that. So I would encourage providers, make sure you're double checking before you hit submit.
Absolutely, spend just a little bit more time up front. What's the old adage, Yagnesh? Like measure twice, cut once. Which I don't know. With my ADD, dude, I just like start cutting everywhere. So your feedback is well said. But how does Magellan evaluate and measure network adequacy?
Yeah, it's a great question. So what we're really looking at is access and availability to look at network adequacy, and really, do we have members who are on a wait list? Yes or no? And so it's something that I do want to recognize is the challenge that this industry has been going through through this last year, right? Year plus. We've really seen, and it's not just Magellan, we've seen it across the board, RBT shortages, behavior analyst shortages, right? So we've seen that access and availability really shift and change. And so what it's helped us to do is really start to look at innovation. How can we start to look at network adequacy? So things like we have some providers who are looking at a parent-led approach to ABA. We have some that are looking at a BCBA only led approaches to ABA. Again, looking at the case rate and the value-based model. How can we start to spur innovation through that? Really leaning heavily. If there's any good things that ever came out of COVID, is telehealth. Right, and the utilization and the adoption of telehealth services, and so how can we start to use more and more with telehealth to get individuals into services timely as we're starting to build up their programs? And so network adequacy is near to our hearts. It's something that not only do we take really seriously, but also regulators are also monitoring very closely in every state. If we don't have network adequacy, that's on us to be able to fix. And so constantly having conversations with providers like Ascend, right? Around, hey, what can we do differently and with greater innovation, and how can we work together so that individuals aren't on a wait list?
Powerfully said. And my ask of my colleague ABA providers out there is, if you have a BCBA that leaves, look, reach out and term them with the payer, right? Otherwise, all the payers are going to have multiple BCBAs across their their credentialed roles. So really important that that's a really big thing at Element. My other organization is just make sure that payers are notified, right? So that BCBA is not sitting on every payer's role. But what are some of your biggest predictions for our field in the next 5 years?
Yeah, I think one of my biggest predictions for our field is greater integration into a multidisciplinary approach to autism, and getting ABA to take a step back away from radical behaviorism, in that ABA can fix everything. And by the way, I say that as a guy who's got a tattoo of B.F. Skinner on his body, right? So, I'm a big believer in Skinner. Everybody knows that, who knows me. But we have to be able to, again, coming back to it, we have to deconstruct that, and that ABA is just going to fix everything, and start to look at a multidisciplinary approach. But I think the thing, Jonathan, is that for so long, when we think of multidisciplinary and autism, the ubiquitous approach within that is, cool, OT, PT, speech, got that. But we have to start to work in consistent and ongoing testing and reevaluation of autism, right? The University of Washington a couple of years ago reevaluated 1,500 individuals with an autism diagnosis. They found that 9% should have never been given a diagnosis in the first place. And an additional 4% lost their diagnosis over time. So you're looking at 13% of an overall population of 1,500 individuals that could have got services elsewhere, that could have got their clinical needs met in other clinical areas, but instead, potentially, we're looking at this narrow scope of ABA. And so a multidisciplinary approach would be able to track that, look at that, schedule that consistently, right? It's almost like a Costco model, right? You're in one shop and everything you need is right there. And to me, I think that's what I'm seeing is a greater appetite from providers around that multidisciplinary approach.
Oh, it's so important. Again, just we have to look no further than the rest of healthcare to see the benefits of doing that. Yeah. Well, Yagnesh, what's one thing every ABA provider should start doing and one thing they should stop doing?
Ooh, that's a great question. I think one thing that we can start doing is how can we better support our young clinicians who are coming in this field? What I'm, again, 18 years in the field, and I feel like a relic oftentimes now when I'm talking to folks, is the clinicians now are coming in my opinion, hungrier, with greater drive than when my colleagues and I came in 18 years ago. They're coming in with greater knowledge, right? I'm going to say a term that might be divisive or not. They're coming in far more woke than we ever were, Jonathan. They know, right? They know things that we never knew back then, and it's beautiful. So how can we harbor that? How can we support that? How can we grow young clinicians into being in this position that, Jonathan, frankly, you and I are in, right? And I think if there's something that I would like providers to do is really tap into that youth and that excitement and that energy, and do things like rounds discussions, introduce them to other medical professionals, introduce them to journal clubs, start getting them research articles, not just in ABA. Because guess what? They passed the BCBA exam. That was hard, right? That was challenging. I don't think we need to teach them more ABA skills and techniques. I think what we need to do is teach them what else is out there with autism, right? What else can we be doing? And so I think that's what I would like for them to really start to do, is support that youth and really hitch our wagon to that youth's energy, because it's fantastic. Now, so Jonathan, I think what we should stop doing in ABA is, I think we have to stop looking at our intervention through this homogenous lens of what we believe as neurotypical individuals is the best intervention or best case scenario for that individual. And the example that I'm going to come back to time and time again is stereotypy or stimming, right? And what we continue to hear from the autistic community is, who cares if I'm stimming? What does it matter? But yet we have so many providers who are saying, no, they can't stim. We got to get rid of that. We got to get down to zero. For what? For what, right? We all have idiosyncratic behaviors. We all do things as self-regulation that make us feel good inside, right? What gives us the right to tell an autistic individual, stop doing what makes you feel good because I told you to? With no scientific backing, with no understanding of what the industry is saying, or not even listening to the autistic community. And I think what we have to also do, in coming back to what we should continue to do for providers, what we start doing is we have to listen to autistics. We have to listen to them. And we also have to listen to the criticisms in the past, the ugly history of ABA, and why many people within this community hate ABA. We have to come to terms with that. And because if we don't come to terms with that, we're really not doing a service to the community. And so how can we start to tailor our programs around what is it that the communities actually want, versus in my homogeneous, narrow scope, this is what you should be doing instead.
You know, that resonates actually, like, really deeply and personally, that around stereotypy. And Yagnesh, you know, my son, who's now 12, but when he was like 3, and this was before I even got into our beloved field, you know, he would do like stereotypies. He would kind of raise his hand, and we asked the pediatrician about it. And the pediatrician was not a BCBA. You know what he said? He said, "Hey, I mean, is it really socially significant or not? Is it really a big deal?" And we were here thinking, should we enroll him in like a Johns Hopkins study or do something else? And Jackson doesn't have autism. You know, he's neurotypical. But I think that's a great reminder that, let's listen to those who are out there, and let's acknowledge all of our history. Powerfully said, man. Yagnesh, where can people find you online?
LinkedIn. I'm definitely on LinkedIn. Believe it or not, I think I'm the only Yagnesh Vadgama that's on LinkedIn, so it might be pretty easy to find me out there. I'm also on Twitter, Yagnesh the BCBA. I'm on Twitter there. And also email, right? And I'll just go ahead and say my email, yjvadgama@magellanhealth.com. Jonathan, you know, and I hope your listeners know as well, I'm open, I'm honest, I'm upfront, and you know, I'm wildly invested in the success of not only our industry, but in the individuals that we're all here to serve. So whatever I could do to better serve, any questions, comments, answers, I'm here.
And having known you over the last 3 or 4 years, I know that is absolutely true. You respond to your emails and you are always thoughtful. So this has been really neat. Are you ready, sir, for our hot take questions?
Let's do it.
Here we go. You're on your deathbed. What's the one thing you want to be remembered for?
The love of my friends and my family. And that's what I want to be remembered for, is my appreciation for, I recently turned 40, and my wife asked me to give a speech in front of friends and family. And the one thing I said was, I'm so lucky to have been a part of the journey of everybody that's there. And that's what I want to be remembered for, is being along for the journey of other people's successes and their journey along in this beautiful thing that we call life.
Love it. What's your most important self-care practice?
Exercising, working out, reading, and sleep. I can't stress that enough, man. Sleep.
Oh, so true. By the way, for those of you watching on YouTube, because we have a YouTube channel, Yagnesh has some guns, dude. You can see his pipes here. I think that tattoo. I don't know if that's your Skinner tattoo, but that's pretty sweet.
I'll actually show it for those.
Oh my gosh! Stop it! We're seeing a pigeon with the head of BF Skinner, and it's on his delta, his upper bicep shoulder muscle. That's freaking awesome, my man.
Thanks.
You're invested.
I'm in deep.
What's your favorite song?
Oh man, my favorite song is. This is probably this is personal to me now, because my daughter is 5 years old, and I'm a OG old school hip hop head by at heart, and my daughter is now in breakdance, and she's been breaking now for over a year. Yeah, it's just beautiful. It's incredible to see. And so I recently got her really into a Tribe Called Quest. So anything on the Midnight Marauders album is golden for me.
I'm just going to put it out there. Scenario is one of the greatest songs of all time, not just hip hop.
Yeah.
Unbelievable. Oh, all right. I'm going to drop a link to that in the show notes too. That's very important. Is it mirrors like breakdancing, Birkenstocks, like Tribe, like everything was cool when I'm 46. I'm a little bit older than you are, but like everything was cool when we were young. It's all coming back.
It's all coming back. People know culture, man. They want the culture.
Right. Well, if you give your 18-year-old self one piece of advice, what would it be?
Listen more. You know, I think that when I was younger, I was a little way too cavalier in my approach, and I really didn't take the time to listen to those who had paved the way more, right? And I think I was too eager and energetic to try to pave my own path versus let me see the paths that other people had paved and how can I learn from them.
Nice. And I'll have you know, listen, Yagnesh, is an anagram for silent. Ooh, fun fact for the day. Powerful though, yes. You could only wear one style of footwear. What would it be?
If I could only wear one style of footwear, it'd probably be either Air Max in the air. I'm looking at probably the Air Max 90s or the Air Max 1s, or Ultra Boost, because they're the most comfortable shoes ever made.
Oh, I love it, dude. Spoken like a true old school baller, basketball. I don't know if you are a basketballer, but hey, man, thank you so much for coming on, sharing so freely of your wisdom and what you see our feeling. And thank you for your passion for serving kiddos with autism, Yagnesh.
Jonathan, the pleasure's mine. Thank you so much for this.
What up, listeners? Hey, I got something for you. If you like my Building Better Businesses in ABA podcast, you're going to love the Behavioral Observations podcast with Matt Sikoria. So I recently met Matt at ABAI, and let me tell you, I was just an instant fanboy. Matt's the real deal. His pod is all about stimulating talk for today's behavior analysts. So session 191 on his pod is on the behavior analysis of lying. That's right, lying. How awesome is that? Who does that? He also talks social skills, ACT, FAs, and so much more. His guests include Greg Hanley, Jonathan Tarbox, and other legendary names in our field. And as a BCBA, you can even get CEU credits through Behavioral Observations. You can find Matt and the Behavioral Observations podcast on iTunes, Spotify, Stitcher, or your favorite podcast channel. Enjoy, friends.
Thanks for listening to Building Better Businesses in ABA podcast. Stay tuned for our next exciting episode. In the meantime, please like, subscribe, share, and comment. We value your feedback. Don't forget to follow us on social media at elementrcm.ai.